Good morning and welcome to a Let's Talk Parkinson's event from PCLA on a very important topic, gut issues in PD and how to treat them. I'm Judy Yaris, Vice President of PCLA, Parkinson's Community Los Angeles. We are an LA-based nonprofit that provides support for families living with Parkinson's. I want to thank our sponsors, Abbott, AbbVie, Boston Scientific, and Medtronic. Free programs like this are also made possible by donations. If you appreciate free programs like this one, please consider making a donation on our website at pcla.org. So before we start, we have a few notes for this event. We are recording today's program, but your image will not be visible in the video. Please stay muted to keep background noise at a minimum. And also, if you have questions or comments or want to share, type them in the chat. And please keep your questions on topic. It's really my great pleasure to introduce our speaker today. Dr. Wael El-Nashef joined UCLA for clinical fellowship training in gastroenterology and earned a PhD from Caltech. He performs research at both Caltech and UCLA, and his clinical interests include gastrointestinal complications of neurodegenerative disorders such as Parkinson's disease. So, Dr. El-Nashef, I'm turning it over to you. This is a hot topic, so tell us what you know.
Well, thank you very much for inviting me to speak and for that introduction.
Okay, sorry about that. Minute here. It sounds like we had a little technical problem.
All right, are we good?
I think we're good to go.
Okay, great. Well, yeah, basically, as Judy mentioned, I'm a physician scientist. Most days of the week, I'm doing research, like basic science research, in a laboratory, and I'm a gastroenterologist by clinical training, and I do a lot of work in the enteric nervous system space. And so I started collaborating with some of the neuroscientists and neurologists at UCLA, and they said, hey, you have to start a clinic for our patients with Parkinson's. All of them have GI issues, and it's really difficult to manage, and it would be great if someone focused on this. And so that happened a little under 2 years ago, and it was kind of in a pilot mode for a while, and then we've started formalizing it, and we've gotten a lot of experiences from that. I believe, when we were starting out, we were probably the only dedicated clinic for that. There have been a couple of other clinics that have popped up since, but it's a growing area of interest. But there's no textbook on how to manage these problems. There's no instruction manual. And so I've learned a lot, and I think I have a couple of good practices in terms of how to manage some of these problems and how to think about them too. So, yeah, there we go. So first of all, I don't have any disclosures. I don't get any funding or payments from insurance companies or pharmaceuticals, et cetera, like that. I do have an NIH, government-based grant. But I saw this slide, and it really, hit home with me because, when I was learning about, Parkinson's disease as a medical student, I mostly knew about the tremor and the motor symptoms. However, as I learned more through training and then now, I've learned that there's so much more to Parkinson's than the motor symptoms. And I was just telling the other folks on this call earlier that, most of the patients I see will say that, the motor symptoms are a nuisance, they're not fun, but what really is driving their quality of life are the non-motor symptoms. And specifically in my clinic, it's the GI issues. And so this is a really important topic. And so, this is probably very familiar. There's the Parkinson's disease, there's the motor symptoms of Parkinson's disease, like the tremor, bradykinesia, rigidity, and postural instability. Then there's the non-motor symptoms. And obviously today we're going to focus on the GI issues. And we say the word dysmotility, and motility means like movement, and dys means abnormal. So it's not necessarily, it can be slow movement or abnormally fast movement or absence of movement. It's a very vague word, but it's about movement of the GI tract. And this is the first description of Parkinson's disease by Dr. Parkinson himself. And this was roughly 200 years ago, I believe. And in the very, very, opening, description of this disease was this recognition that GI issues are a really big part of Parkinson's. And, James Parkinson describes how people have had a long history of having constipation, essentially, and that things get worse, and then they have to take a lot of medications just, to get things going. And sometimes they need mechanical aid. And, we would call that like manual disimpaction. But over the decades, these sort of GI issues have sort of been studied, mostly because there was so much excitement that we were starting to learn the cause of Parkinson's, the cell types involved, the role of dopamine and therapeutic potential for that. And I feel like GI issues sort of got underappreciated. But moving forward, though, we're starting to realize GI takes a big role in the patient's lives, and from a basic science standpoint, it could also play a role in in how the disease starts. There's a lot of research suggesting that maybe Parkinson's in some patients begins in the gut and then spreads to the brain. So that could be a really huge paradigm shift in how we think about Parkinson's. This is just a little bit of background, some more. I'm sure many of you are aware of like the Lewy bodies, this is like this clumping of this protein called alpha-synuclein, and this clumping is toxic to the nerve cells, and it can spread from cell to cell. But it appears that the nerve cells that produce dopamine tend to be way more sensitive to this sort of Lewy body damage, and they're the first ones to go. And so if you can see my mouse cursor, you see this black strip right here. This is the dopamine producing cells in a normal brain. And this is, in a Parkinson's, there's none of that black marks, which are the dopamine producing cells. They're the first to go. Now, if we think about Parkinson's disease, and we think about the GI issues, do we have shaking palsy of the gut? So there have been Lewy bodies observed in the nerve cells in the intestine. And patients have been shown to have fewer nerve cells in their intestine compared to people without Parkinson's. And so just a quick anatomy lesson, as if you look at imagine you cut an intestine like a pepperoni slice. There's a lot of nerves. So these red things are clumps of nerves between muscle layers and underneath the inner lining. It's a very complex nervous system with a lot of nerve cells. In fact, there are as many nerve cells in your intestine as there are in your spinal cord. And if you took the intestine out of your body and put it like in a tissue bath, it could function independent of your body and like do peristalsis and move things around. So it's a really complex nervous system. And not only does it function on its own, but it communicates really intimately with your central nervous system, with your brain and spinal cord. So the enteric nervous system, the nervous system of your gut, is really complex, and it's integrated with the brain. And so this vagus nerve right here, they think of it as like the highway between the brain and the gut. And what's interesting, as I sort of alluded to earlier, is that constipation in a large subset of patients, not all of them, but I would say a third to a half of patients, constipation can crop up years or even decades before people get motor symptoms and diagnosis of Parkinson's disease. So this is -20, meaning 20 years prior to early symptoms of motor Parkinson's disease. There's all these other symptoms as well too, but we're focusing on the GI stuff. And just a crash course on the anatomy, we're going to be talking about the esophagus, which is the food tube. The stomach is, where the chewed up food goes, gets digested some more, and then sent through the small intestine, which is like this bowl of, pasta looking clump of intestine. And that's where most of your absorption of nutrients happens. And then from the small intestine, it goes to your colon, and the colon is sort of like an upside down U. and goes to your rectum. And this is where water absorption happens, and then defecation, essentially. And so when I go through this talk, I'm gonna go colon up, because I think the most pressing issue is usually the colonic issues. So constipation is huge. Now, I say constipation, and there's going to be different types of constipation that we're going to talk about, but also there's diarrhea, which is actually constipation, and then there's also issues with fecal urgency, like needing to rush to the bathroom as soon as you have the urge to go, and other issues that are sort of related on a continuum, like soiling, like in your underpants, there's some leakage essentially, or incontinence, which is when you have like an accident. And these are all sort of related. And then there's bloating, weight loss, and malnutrition. So that it's not purely GI, but that's something that I come across a lot. Poor absorption of medication, specifically carbidopa, levodopa, heartburn and reflux, and difficulty swallowing. Now, I say this is, these are just sort of broad territories of each, part of the GI tract. But, you can see that things overlap in terms of the sort of symptoms they can cause. And so you have to sort of keep an open mind and, listen to the patient, see what symptoms they're describing, and try to think of what makes sense given the situation. So constipation and Parkinson's disease, up to 80% of patients have constipation, and it's probably more. There's many ways to get constipated, but you can have slow transit, meaning that the colon is moving slowly. You can have anorectal dysfunction, and that means that there's a very synchronized coordination of muscle movements between the rectum and the anus in order to defecate. And if that gets screwed up for one way or another, then you get constipated. But the reality is in Parkinson's, the majority of patients have both the slow transit and the anorectal dysfunction. In the early days, when patients with Parkinson's would complain about constipation, physicians would just chalk it up to a side effect of Sinemet. If they'd say, well, that's the Sinemet, sorry, here's some, eat some more fruit or something. But that is actually less clear these days. And in fact, Sinemet may slow down the gastric motility, the stomach's motility, but that's controversial. And it's really not clear what kind of effect it has on the gut. And then patients with Parkinson's are 6 times more likely compared to non-Parkinson's patients to have constipation. And people who have constipation are 3 times more at greater risk of developing Parkinson's in the future. Specifically, this was a study done in men. I think it was a VA study. But it's a significant finding for Parkinson's. So as I mentioned, it's kind of tricky. So, when most of us think of constipation, we think it just means having fewer bowel movements. But that's different in many of the patients I see in my clinic, and I'll show an example soon. Parkinson's patients often don't have a good sense of when they're constipated. And I can just show you a study that was done that was interesting. This is sort of like a fancy CT scan, let's say, and they reconstructed the colon in a 3D image. And you can see these are like the ribs, and this is the pelvis. This is a normal, a non-Parkinson's patient, not constipated. You can sort of see the size of the colon and how it's shaped and how it looks. This is an average Parkinson's patient. And you can see how much bigger the colon is, and it's filled with stool. And then this is a patient with Parkinson's who's complaining of constipation. And so it takes a lot for them for some patients to know that they're severely constipated. And I think it might have to do with the sensory nervous system, and that might be involved, and it might not be triggering, the brain that, hey, there's something wrong. And so oftentimes I get cases like this. This is just like a hodgepodge of patients I've met over the last year or two. So they'll come in, they'll say, I've been, constipated my whole adult life since my 20s. But, things progressed, over the years to get worse and worse, but then definitely got worse by the time I had Parkinson's disease. I used to take Colace and did the trick, but now it doesn't help anymore. And I was just having fewer bowel movements per week. Then about a month ago, really started, things got really bad. And I was just having like frequent small bowel movements, like one every hour basically, but it was tiny, like pebbles. But I was going like every hour, I couldn't leave the house. And if I didn't, once I had the urge, I had to run to the toilet or else I'd have an accident. About a week ago, I started noticing some leakage. So I had to put pads in my underwear. And then my bowel movements became liquid. And so I thought, wow, is this diarrhea? So then I started taking Imodium because it was over the counter and I'm having diarrhea. But now I feel absolutely terrible. I can't eat, I'm nauseous, and I'm having no bowel movements whatsoever. So this patient, this hypothetical patient, they ended up going to the ER. This is before I saw them. And this is what their colon, this is like, again, like they're laying down in the CT machine. There's like a pepperoni slice. And you're looking, this is their colon. The colon is huge and it's full of stool. And they're supposedly complaining of diarrhea, which they're having liquid stools. So what in the world's happening here? So there's an entity known as overflow diarrhea. So, the rectum's, its job is to be a reservoir for stool. And this is how things look normally. And this is, you're looking, sort of facing the anus essentially. This is the rectum making its turn towards the anus. And this is the sphincter here. And, this is the normal appearing anatomy. But if you have a large amount of hard stool that's sort of, impacted into the rectum, first of all, you get, this stool is not going to pass on its own. And it's just sort of blocking things. But what happens is above that, in the other parts of the colon, liquid stool is the only form of stool that's able to work its way around. And it ends up just sort of like seeping through on the edges. But because the stool is so large, the anatomy that related to continence, which is like the anal sphincter, for example, it gets distorted. And so this liquid sort of leaks out. And the only type of bowel movements that come out are liquid. So patients think they're having really bad diarrhea, but in fact, it's super severe constipation. So my first advice is do not take antidiarrheal medications. I say this to like all my Parkinson's patients, that unless you're having severe diarrhea with the threat of like life-threatening dehydration and a physician tells you to take Imodium, that's basically the only scenario where I would recommend it. You might require manual disimpaction if it gets this bad. But you can usually avoid that if you're still able to pass gas, you're not having severe pains, things like that. You can usually clear that by taking a bowel cleanse. It's essentially the same thing you would take for a colonoscopy, like a Go Lightly or a Suprep. But I've had patients where things were so bad that one bowel cleanse didn't do it and two didn't do it. They had to do 3 of them to clear things out. That's how bad it can get. And then after this bowel cleanse, these patients usually require a prescription strength laxative, like Colace isn't going to cut it. So there are different ways of trying to diagnose like slow transient constipation. There's some of you might be familiar with SITS marker studies. Basically, there's these little metal discs that that are in a capsule, and you swallow it, and then when the capsule dissolves, they all disperse throughout your GI tract, and then you take X-rays over several days to track how long it takes for those metal markers, to pass through. It's kind of an old school study, but it works. There's a fancier test called the Smart Pill, and it's basically a wireless pill that you swallow. You wear like a radio receiver on your hip, and it tells you how long it takes to get through the stomach, the small intestine, and also the colon. And that can be really helpful. I've been reluctant to use it in patients who have deep brain stimulators because I haven't gotten clear guidance from the manufacturer if it's safe. And I've spoken with neurosurgeons, and they said it's probably safe. But usually, if they have a DBS and they need this test, we do different tests, like the SITS marker study, for example. Also, the pill's pretty large too, so some patients can't swallow it. In reality, though, as I've moved forward with this clinic, I've realized I don't necessarily need to do these studies very frequently for every patient in order to start treatment. This is usually if things were unclear, or I need to like get an objective measure. So another common presentation of constipation So I'll have patients who'll say, I'll get the urge to have a BM. I go to the bathroom. As soon as I sit down, it's nothing, crickets. It feels like I'm pushing against a closed door and nothing comes out. There's a lot of straining, a lot of pushing. Like squatty potties seem to help a little bit. But when things are really bad, I have to use my finger to help things move along. But I recently tried an enema and it worked out pretty well, actually. That seemed to be quite effective. So this seems a lot different than the first patient. So what's going on here? So this really depends, it's really important to know a little bit about anatomy here. So imagine you're looking at someone standing sort of sideways in profile to you. And so this is the spine, and this is the rectum. And the rectum, when you're just going about your day, is normally sort of held in this kinked position by the muscle called the puborectalis. It's like a sling, and it kind of keeps it at that angle, and it helps provide continence along with the anal sphincter. When you have a bowel movement, this puborectalis muscle, the sling, relaxes and allows the rectum to be straightened, and that allows stool to pass. But if you have something called dysenergic defecation, that doesn't happen, and the rectum remains in this sort of kinked position, and stool cannot pass freely. And that's why patients describe feeling like they're pushing against a closed door. There's a lot of other things that can happen, but this is super common. So how do we diagnose this? We have tests that can look at this. And so there's something called anorectal manometry. Manometry just means like pressure sensors and readings. And so basically you insert this catheter with a balloon at the end through the rectum, and it's connected to like a computer, and we can measure pressure and the muscle contractions of the rectum and the anus. And this will tell us how well those muscles are coordinated with each other and if things are working like they should. It doesn't require any sort of sedation. Usually it's in an office setting. And if it does show dysenergia, there's a sort of physical therapy called biofeedback therapy that you can do, and it's pretty effective, and it helps a lot of patients. Less commonly, there's MRIs you can do. Usually I do this if there's still a question of some anatomic issue, but it's less common. I've done this only a handful of times. Now, in terms of treatments, so there's a lot of over-the-counter medications that are oral that you can take. I'll talk about some of the more popular ones. So there's things like Senna and Bisacodyl or Dulcolax. Those are stimulants, and they work, but the problem is that they can cause cramping, and it's, difficult to predict when they're going to kick in. And I would say it's a good sometimes medication if you have, periodic constipation. But if you need something every day, which most Parkinson's patients do, I wouldn't use this as my go-to. It's just not convenient. It's going to be uncomfortable. There's fiber supplementation like Metamucil or psyllium type fiber. Now, this is generally a very good medication to use. However, just a warning that if you come into this severely constipated and you take the full dose, it can really worsen bloating. So usually I start this, if the patient needs it, after we've cleared severe constipation, we start really small, like 1 teaspoon a day, and then gradually build up if they need it. And then there's polyethylene glycol, or PEG, also brand name is Miralax. This is a very safe and effective medication. It doesn't get absorbed into your body. It just draws fluid into the intestine. As a solo treatment, I've only rarely seen this work for Parkinson's patients. They usually need something additional, but it's well tolerated. And then lastly, the stool softeners. This is, I would say, like almost homeopathic for a Parkinson's patient. And if you're looking to cut out pills from your life, this would be the first one to go. I think it's great for some patients outside of the Parkinson's world, but probably you're bringing a small gun to a bazooka fight, basically. And then there's a lot of magnesium, like milk of magnesium, mag citrate, calm, etc. I would say that a lot of patients use this. I would say my only reluctance is that using it every day has risks. You could build up magnesium in your body if your kidneys aren't working very well. So I would talk to your primary care doctor, whoever's checking your regular labs, to see what their thoughts are. But I think there's probably better options. But for occasional use, it's fine. There's also rectal therapies. I'm talking about enemas and suppositories. Um, and so this can, in the case of dysenergic defecation, this can actually help guide us to that diagnosis. The patient has a really good response to that. That sometimes suggests that it is indeed dysenergic defecation, because the stimulation of suppository and enema and extending the rectum can stimulate the defecatory reflex. And so it can be super helpful for patients to have this in their armamentarium. However, it's not super convenient to do this on a daily basis, but it's totally safe, especially if you're doing like a tap water enema. It doesn't have to be saline, or a glycerin suppository. It doesn't have to be Dulcolax. Now, I just want to say again, please avoid antidiarrheals unless directed by a physician, and it's for severe diarrhea, because it works by slowing down the GI tract. And in Parkinson's, you already have that problem, and it could just shut down your GI tract, and that could be really disastrous. So really try to avoid loperamide or Imodium or medications like that. Now, so this is where I might come into your life, is these prescription drugs. And so I'm going to talk about three of them mainly. And one of them is Linzess. You might know about these. And so this one works. Again, all these meds I'm mentioning here are like really safe, but there's downsides. So this Linzess works by by increasing secretion of fluid into the intestine. And so this, I've had patients use this, and most of them do pretty well with it, but some of them have terrible, terrible diarrhea with it, even with a tiny dose. And so for whatever reason, some Parkinson's patients are very sensitive to it. And lubiprostone, also known as Amitiza, this works in a similar way, also increasing secretion of fluid into the intestine and colon. However, in my experience, based just on anecdotal experience, most of the patients I've seen take this have had really severe diarrhea, and they don't like taking it. So this is my third, fourth, or not even on the table option. But the one medication that I use probably the most, I would say the large majority of patients in the clinic are using, is called prucalopride or Motegrity. It doesn't interact with your typical Parkinson's meds. It's a very safe medication. The main side effects that we see are maybe some cramping that goes away as you use the medicine, or diarrhea, in which case we just reduce the dose. But I wanted to start off by saying there is an FDA warning about like suicidal ideation and depression, which sounds really scary, because of course that is scary. However, when you do a deep dive into where this came from, it was based on just a couple of case reports in Europe when this drug was first being tested. And it's just it's a possible association. And in my experience, I haven't really seen that at all. Like, I never had a compelling example of someone who had that, and neither have any of my colleagues. So I think, we're talking about maybe 3 or 4 case reports out of many thousands that might not even be a true association. It, requires more study perhaps. But I always make the same joke with my patients, is that if anything, patients in my clinic who take this medicine, their mood improves because they're no longer constipated. And so, I think I always advise them, if they've noticed any changes in their mood, just stop it, call me, we'll figure it out. But I haven't really had true concerns for that side effect. The other issue is that it's very expensive, and there's no generic, and it takes a lot of paperwork to get it approved. And so if you get a prescription from your doctor today, you won't be getting it tomorrow. It probably takes a week or 2 to sort through all the mess. But once you get your access to it, can be really life-changing, because not only does it help with the constipation, it speeds up motility throughout the entire GI tract. So you can imagine how beneficial that can be, because usually patients don't just have constipation. They have slowed stomach and a slowed small intestine, etc. So this medication, I usually pair it with Miralax, because Miralax is going to make the stool softer because it's drawing in fluid, and Motegrity is going to work by increasing contractions. So it's sort of synergistic, and it seems to work really well. The next common issue I hear a lot about is bloating. So, we say bloating, and it's just a little bit of maybe semantics for the general population, is there's bloating and there's distension. So bloating is what you feel, distension is what you see. So some patients say they're bloated, but visibly you can't, they're the same. Some patients are distended but feel fine. But I think what most patients in the clinic come in with is bloating and distension. So, there's a lot of possible causes, but the most common cause I see for bloating is constipation. I'd say it's the top three, 1, 2, and 3 causes. And usually, most patients, once we successfully treat the constipation, they're on a good regimen, bloating gets dramatically improved. But there's other things you got to think about. There's something called SIBO, small intestinal bacterial overgrowth, which I'll talk about. And then there's also gastroparesis, which isn't really truly bloating, but the patients might perceive it as bloating. And we'll talk about that later too. And lastly, there's the common things for everybody that, certain dietary issues can set off bloating, certain food intolerances and gas producing like veggies and stuff can cause bloating. And these are things you can just avoid if they cause those problems. So small intestinal bacterial overgrowth. So it's in Parkinson's disease. It's not super well studied, but about a third of patients who have some common GI symptoms will test positive for SIBO. And then usually we treat SIBO with antibiotics. However, in Parkinson's disease, after 6 months, about half of the patients get SIBO again. It comes back. So the theory is that what's causing the SIBO is that there's decreased motility in the small intestine. And that if you just treat with antibiotics to get rid of the excessive bacteria, the underlying cause is still there. And so it'll just come back. So one way to deal with that is to give a prokinetic medication like Motegrity to speed up the intestine, and that should help prevent it from relapsing. This is still sort of, this is still being studied, but that's usually people's approach, is to actually, if you do test positive for SIBO, give the antibiotics, but also start something that'll help prevent it from returning. And so SIBO isn't, it isn't technically an infection. It's an overgrowth or excessive amount of bacteria that are normally in your small intestine. And there's usually a small amount in everybody's intestine of bacteria, but then you clear it out with your contractions and peristalsis and push it into the colon and expel them. But if your motility is slowed down, that's not going to happen as much. And those bacteria are going to reproduce and divide, and and you're going to have too many of them. And they produce byproducts from their metabolism, such as gases. And those are most commonly hydrogen, but also methane. So that's what's causing the distension and the bloating. The way we test for it is actually through a special type of breath test. So we can, we usually just mail a kit to the patient's home with a series of test tubes, and they just breathe into these tubes over a certain amount of time, and then send them back to the lab, and we measure how much hydrogen and how much methane are in those breath samples. And we can tell if there's an abnormal amount of certain populations of bacteria based on those results. And in this example, the patient has a normal amount of hydrogen, but an abnormal amount of methane. What's interesting is that, well, this patient had Parkinson's, and also methane, if it's methane that's causing the SIBO, methane producing bacteria, that version of SIBO is associated with constipation. Well, other types of SIBO are associated with diarrhea. So it's good to know what type of SIBO you have. But my thoughts are, most of the time, when I first started the clinic, I was testing everyone for SIBO, and I would say like half the patients were testing positive, and they were getting antibiotics, et cetera, which is fine. But during the pandemic, et cetera, there were sometimes delays in the patients getting the tests, and getting the results and all that. And so I just started them on treatment. And I noticed that many patients' bloating went away. And so I learned that really most of the bloating probably in this patient population is not SIBO, it's just constipation. And I reserve testing for SIBO only if the patient still is bloated after we've successfully treated the constipation, or if they have a vitamin B12 deficiency, because in SIBO, the bacteria consume vitamin B12 in your intestine before you get the chance to absorb it. And so you can get B12 deficiency from that. So if they do have that, I think it's worth testing and treating. But I don't just test everyone anymore. The other, thing I mentioned before is gastroparesis. And this is sort of like a form of stomach paralysis. And so the stomach is, different than other parts of the GI tract, is that, your stomach is usually pretty small, but when you eat, it has to expand, relax, and accommodate all the food you're eating. And then it has to grind the food, but keep it from going, up your esophagus and keep it from prematurely exiting the stomach. And then when that's done, it has to push the food into the small intestine. This is very complex. So you can imagine if something were to go wrong, it'd be very easy for it to go wrong. So patients with Parkinson's disease can have dysmotility in the stomach from multiple, levels. And so, first of all, levodopa, some studies suggest it slows down the stomach as a side effect. It's inconsistent, the studies, but most of them suggest it. But also the Parkinson's disease itself can directly involve the nerves in the stomach and the nerves going from the spine and the brain to the stomach. And so that can also affect the movement of the stomach. It's a very difficult condition to treat in Parkinson's, but it's super important. It's a priority for me to make sure it's managed. So this is what a typical case I see looks like. So over the last 3 years, I've lost 15 pounds, but 7 of those pounds I lost were just in the last 6 months. And the problem for me is I love eating, but as soon as I take a few bites of food, I get really uncomfortably full. I can't eat anymore. And then even after a couple of hours, I still feel bloated and I feel like there's just a brick sitting in my stomach. And compared to a few years ago, I used to eat a whole plate of food. But now if you put that plate in front of me, I could only eat a third of it because of this discomfort. And also I've noticed, during this last year or so, I've had to increase my dose of levodopa and it's just not working as well. I'm not getting to my on times and it's wearing off faster. So what are common causes of the symptoms that this patient described? First of all, weight loss. So there's a lot of reasons patients with Parkinson's lose weight. One of them is that you have to time your dose of your levodopa with your food. Also, you may have lost your sense of smell and taste, and food's not as appetizing. Might have difficulty swallowing. Could be depression. There's a lot of causes. Like we mentioned, bloating, constipation, SIBO diet. But when there's also this aspect of poor absorption of levodopa, that kind of points my mind to gastroparesis. Because, when you time your dosing of levodopa, like an hour before meals, that's presuming that you have normal emptying of your stomach. But in gastroparesis, some patients have food that just stays in their stomach for hours. And so when you think you're on an empty stomach, you take your levodopa, it's still full of food, including protein. That's going to interfere with the absorption of levodopa. So, there's, when we have gastroparesis and other diseases, we say, well, just eat small, frequent meals. Well, that's going to be impossible if you're taking levodopa every 4 hours or something. Then there's a medication called metoclopramide or Reglan. So this, works, by blocking dopamine receptors, but it also it does that in the gut, but it also does that in the brain. So it can make motor symptoms in Parkinson's worse. So I would say do not use this medication if you have Parkinson's. And there's something called domperidone, which is like Reglan. However, it doesn't go into the brain. And it works well for gastroparesis. However, it's associated with increased risk of cardiac side effects and even sudden death. And so for me, I don't like using it. You have to go through a whole process with the FDA to get permission to use it. And I haven't prescribed this drug in years because the truth is we have Motegrity or Procalcrin. This is much safer and it appears to be effective in gastroparesis, including in Parkinson's. And it also benefits the constipation and SIBO and the small intestine. So it really checks a lot of boxes and it's safe. So I'm going to move a little quickly with the swallowing issues. So we say swallowing issues, the term for that is dysphagia. And so you can have dysphagia from your esophagus. And that's, most patients will describe it as food getting stuck in their chest, or they'll have like pain when they swallow. They'll have to drink a lot of water, push things down. It can be associated with reflux, like heartburn type symptoms, or stuff coming up again. Not necessarily vomiting, but regurgitation. But you can also have what's called oropharyngeal, meaning like upper throat dysphagia. And there's a lot of different muscles involved in swallowing. And this can present more often as like choking or coughing when you eat, difficulty swallowing pills. And you can go based on symptoms, but you really have to do tests to for sure diagnose which one you have, or if you have both. But regardless of the cause of the dysphagia, this is associated with something called aspiration pneumonia. And that's basically when whatever you're trying to swallow goes down into your lungs instead of down your esophagus. And that can be really deadly and really serious if this goes on for a long time. And so this is something to take super seriously, not to ignore it. If you're having these issues, I think, the first place to go is the ear, nose, throat doctor and the speech pathologist, but also the GI doctor can help too if there's concerns about the esophagus contributing to that. So some hot tips that I've learned along the way: avoid opiates if at all possible. And it's really easy for doctors to say that, but I've had patients who had to get orthopedic surgeries, so they're going to need opiates. You can't just say don't take them. They really need them at least for a short period of time. But luckily, there's some newer medications that can block the side effects of opiates on the GI tract. And so I would, remind your physician, like, hey, I have Parkinson's. Opiates are going to shut down my entire GI tract. Maybe you should, pre-dose me with naldehyde, and that'll help. I think sometimes, in the hospital setting or in the surgery setting or an emergency room setting, this might sort of fall back in people's minds because they're focused on the more urgent issue. But this will save you a lot of trouble moving forward, and it's safe. And then if you're having any of these, GI issues, I would say you need a colonoscopy and most likely need an upper endoscopy. And so, if you're going to go to a specialist, subspecialist like me or something, have those up to date and have the records ready because we're going to ask for them. And, it's Colon Cancer Awareness Month. So, even if you're not having these issues, make sure your colonoscopy is up to date. And then I think what's really helpful is finding a registered dietitian who knows their PD issues. And a simple way to check is that you can sort of test them and see if they are familiar with the levodopa absorption issues with protein. And that'll let you know right away if they're savvy to these issues. Because, a GI doctor is going to focus on different things. Like you could spend an entire hour with a dietitian talking about the nutrition issues. And then for severe constipation, if you just take a pill, no matter which one you take, it's probably not going to work. If you have really severe constipation, you just have to do a bowel cleanse. Otherwise, you're just going to be chasing your tail. And so I have had patients try to avoid that, but then it just delays things and they're miserable. So, just be prepared for that possibility. And then while you're waiting for a GI appointment, let's say you made an appointment, it's in a week or two, try taking an enema or a suppository. You can get this over the counter and, try Miralax. So when you come to your appointment, you say, enemas work great, then that definitely helps narrow my thinking as to what's going on. It can help speed things up for you too. And then while bloating or nausea might be a huge concern for me, the really scary things are weight loss, because that leads to muscle mass loss and falls. So I take that super seriously. Dysphagia with the aspiration going down the wrong pipe, because the pneumonia can kill you. And then if you have new or sudden severe abdominal pain, there's a lot of reasons that can happen, but don't ignore it, go to the ER. But let's see. I wanted to leave some time for questions. I have a whole list of questions that were emailed to me earlier, but basically, I would say I'm happy to answer general questions. If you have a very personal, question about your own medical condition, this might not be the best forum for it because it's obviously very public. But yeah, I think there's a lot of interest in the microbiome, et cetera. I'm happy to take any sorts of questions like that too.
Yes, thank you so much. For myself, I just want to say you just answered 18 years of questions that I had when my husband had Parkinson's disease. So this was amazing, really fantastic presentation. We have quite a few questions, and I know, there was one that was sent in earlier about the microbiome research and relationship with PD, and I wonder if you could address that for us.
Yeah, I think I'm always a little bit. I'm the one who's dragging my heels the most in the microbiome and like the GI world. There's because like I think there's so much enthusiasm about it, and I agree, it's super exciting. But I just want to make sure that the enthusiasm doesn't outstrip the science. And so I think it's still very early. There's a lot of exciting things that we see, like in mouse studies, that really point to the microbiome. But ultimately, it's going to take more research to determine how that applies to humans and with Parkinson's specifically. There are some, related to that. There's like fecal microbial transplant, like fecal transplants. There's at this point, it's more on the case report status, and there are some good reports of that. But until there's like really well-designed studies that are randomized and blinded and all that, I think we just have to sort of be patient and wait. I've had patients who gave themselves fecal microbial transplants at home from like their spouse, and like people are very excited to go this route, but there's not that much data yet to go that route. So I would say, just FYI, it didn't help her, and probably made things awkward at home for a week or two. I don't know, but basically, it didn't really help her. But I think we'll just have to wait and see for that.
Okay. There was one other one along the way here that we've had so many questions, some which are not as related to this, but a lot were diet questions. Someone said, I follow the MIND diet and increase fiber intake, which seems to help. And why do you need to pair the Montegrity with a PEG? Do you have any thoughts on that?
So I would just say the usually when a patient is in my clinic, it's like severe constipation.
Mhm.
And so, I know that's not reflective of the general Parkinson's population, but I'm seeing like the most severe of the severe. And so usually the part the Motegrity is a good start, but it works but just by increasing the contractions, for example.
Mhm.
The Miralax works by softening the stool. And so when you put them together, it's a really good combination because they work in two different ways. And so like I wouldn't recommend doing Motegrity and like Dulcolax. That would probably cause a lot of cramping because they're both increasing contractions, for example. But that's usually my approach, just to have an effective but also comfortable and realistic regimen for the patient to take on a regular basis.
And what about some of these natural things? Somebody wrote about bentonite clay. Is that it's natural, it's organic? Do you have any feelings about using those?
I'm not,
Devotees, people mention those things a lot.
I'm not too familiar with that. And so that's not to say that it's not helpful, but I've not heard of this form of clay. But there's other natural things that work really well, like chia seeds. People love that, and so that can be really helpful for some patients. I think these sorts of approaches, like a registered dietitian, they're going to know this stuff inside out, and they'll tell you exactly like how to take the clay or whatever that might be, whatever supplement you might need, or they might say, actually, the literature doesn't really support it. Like there's been research and it doesn't really help. But there are definitely like psyllium is just a fiber that's in from a plant. It's totally natural. So like I'm open to those if they're effective
Mhm.
and safe, obviously.
Right. And then there was one question saying, does PD start in the gut? I know there's some theories
Yeah.
about this, that maybe
Yeah, so I think
Be happening.
so when I first started the clinic, my bias was that it did, and so and there's there's a lot of really exciting studies that were coming out in animals where you could like inject alpha-synuclein into the gut, and then the alpha-synuclein would travel to the brain, and several studies like that. Um, but what I found was that patients didn't read those studies, and they don't necessarily follow the biases you have in your mind. They're going, and so what you have to do is just come at it a little more open-minded. And what I found really, roughly speaking, I'd say about a third to a half of the patients I see had GI issues for years before the diagnosis of Parkinson's, but the rest didn't. Some of them lost their sense of smell many years before, then developed Parkinson's, and then developed the GI issues. And it could be that the Parkinson's in that group of patients started in the olfactory bulb, the nerves of the nose, and that's how it spread. But these are all sort of theories right now. But so I think there's probably a large group of Parkinson's patients that it does start in the gut, but we're still sorting it out. But it's not everyone.
And there's one question, and I'm sure a lot of people are asking this. How do you find a gastroenterologist with PD experience? Any ideas on that one?
Yeah, so I would say probably the best bet if you're having like pretty tough GI issues is the best bet is to look for a gastroenterologist or a group of GI doctors who have a motility subspecialty within them. You know, so motility it covers not just Parkinson's but like other diseases that can slow down the GI tract, but they'll have encountered many Parkinson's patients, and they'll be familiar with some of these issues, pretty very familiar, and comfortable with the medications that are, well suited for Parkinson's patients, and also know to avoid things like Reglan, etc.
Right. Is there a connection? We have another question here. Is there a connection between PD and ulcerative colitis?
Yeah, so there again, it's not like 100% proven, but there's pretty strong clinical research to suggest that having inflammatory bowel disease, such as ulcerative colitis, predisposes you to developing Parkinson's later. And there's a lot of theories as to why that might be. But like, ulcerative colitis is inflammation within the colon. And if you have chronic uncontrolled inflammation, it can, we know that can perhaps trigger the alpha-synuclein that you might have a little bit of. It might trigger the alpha-synuclein to clump into the Lewy bodies. And that's the theory. And so there does seem to be an association. And I've had a handful of patients who've had IBD and then developed PD.
Okay, great. Thank you. Somebody else is asking, when is it time for duodopa? Is that something that you are recommending or?
So my understanding is that unless my understanding is that it's still under like a clinical trials, like phase 3.
Right.
But we have patients at UCLA who do that. It's usually for patients who are having really severe difficulty getting level dosing of their levodopa, carbidopa levodopa.
Mhm.
But I usually defer those sorts of decisions to the neurologist taking care of the patient.
Okay.
I think it can be a very powerful way to get good control of Parkinson's, but there's risks with it, and there's also lifestyle issues with it too. So it's really and of course it still is completing its trials. So it's a bit early, but if you're very motivated and if it's something that you could see being compatible with your lifestyle, it's a very reasonable thing to consider.
Mhm. Do we want to open it up now? If we have, these are things that have come through the chat and people have sent in advance. But if we have anyone that would like to unmute themselves and ask a question, we are more than happy to take those questions now.
I would love to
Okay.
ask a question if I could, Judy.
Sure, Charles, go ahead. I noticed you had one in there and I wasn't sure if it was answered or not.
No problem. It's a sort of a multi-layered question. my dad had an advanced stage, and he was in an assisted living facility due to a very long, complicated story that I won't go into. But as a result, he was beholden to their doctors as well as the hospice doctors that he was with, and he was diagnosed with gastroparesis. But they did give him metoclopramide, which after he passed was unfortunately when I realized that it was contraindicated. And so one of my questions is, what can we do to sort of provide an interdisciplinary outreach to educate the wider array of physicians who end up treating Parkinson's patients to ensure that accidents like that can be sort of mitigated?
Yeah, that's, an interesting point. And I think a couple of thoughts. I mean, without getting into too much detail, like how long ago was this?
He would have been put on that probably a year and a half ago or so.
Okay, so not too long ago. So yeah,
Yeah.
I was going to say, like, maybe that was like the only option, and things were really bad. But I think it's this is, I think, more of like a systems issue, and like it might be. Well, I'm just thinking of solution, like a quick solution that'll be effective, because this is somewhat of a niche issue, but it might be the simplest way to deal with it is to report metoclopramide as an allergy on a patient's med list, for example, because that'll trigger all the alarms on the computer systems and in the notes. It'll be everywhere. Don't give this patient metoclopramide. But I don't know what the solution is for that though. But now, especially now, we have better options, and it's not guaranteed that they're going to have extrapyramidal symptoms, but it's like, why do that when there's things that are safer and probably more effective. So, but I think probably the simplest thing is writing, including that as an allergy on your drug list, because that'll immediately, like, it'll stop any doctor from prescribing it, stop any nurse from administrating it. So it's probably the quickest way.
That's a great solution. I like
Yeah.
that idea.
I
Thank
have
you.
a question.
Yes.
How do you avoid indigestion from getting indigestion after you eat?
So I think that's a tough question, because there's, like there's a million ways to skin a cat, and there's a million and one ways to get indigestion with Parkinson's. And so it really depends on what's causing the indigestion. And so, and also the term indigestion. So usually when I'm sitting with a patient, I really dig in to get to the nitty gritty, because it can mean a lot of different things to different people. But just playing like the odds, if you have Parkinson's and you're experiencing symptoms like indigestion, it could be gastroparesis. And so it might be an issue of starting a medication that helps speed up your gastric emptying time, speed up your stomach, or avoiding certain like fatty foods that might slow things down more. But generally, like those sorts of dietary recommendations for gastroparesis and Parkinson's aren't great, because a lot of patients are losing weight. You want them to eat fat. So most of the time it would be a medicine approach to fixing this. If it's more of a dietary issue, like you're not, you're eating certain foods that trigger symptoms, then it might be good to talk with a dietitian to help come up with a game plan of what to eat and how, and how much and when to eat, etc. The thing that I see a lot happening is when patients have these sort of GI symptoms like indigestion, and then they just stop eating things. And then before you know it, the only thing they're eating is saltine crackers, and they're losing weight. And so I think that's not a good way to approach it. I would say, if there's a concern that it's food triggered, get in touch with a dietitian, but also get in touch with a GI doctor to see what might be causing these symptoms. Like, you're just because you have Parkinson's doesn't mean you're not allowed to have an ulcer or gastritis. You still should get the regular stuff checked out too. But if it's indigestion to the point where you're not eating, you're losing weight, like that should be a priority that you get checked out before you lose muscle mass and get weak and lose balance, etc.
Thank
All
you.
right, thank
We have
you.
a hand up. I'd like to just take this real quick. Alexandra, can you unmute yourself and ask your question?
Yes, many of the diets recommended for Parkinson's patients with constipation are full of fiber. And yet we're working with a GI doctor who recommends a low residue diet because of the risk of developing, I don't know, what do you call it, a bolus or something that stays in your gut and
Bezor?
doesn't move because
Yeah.
of not moving, because
Yeah.
of low motility in the system. Can you comment on that? And also another comment about the Botox injection to open the pyloric valve for the stomach in gastroparesis.
Yeah.
Thank
So first of all, so when we're getting to the point where they're worried about like forming like I think what you're referring to is like a Bezor, like a collection of indigestible mass or whatever that could, yeah, that's, pretty significant dysmotility. And so, at that point, I'll defer to them, but it might make sense to go a low residue, but to try to find ways of improving the motility of the GI tract. And so, considering things like motegrity. Again, and I feel like I'm a cheerleader for motegrity. And I swear to you, I am like not connected to the pharmaceutical company that makes it. If anything, they probably hate me because I'm always battling with them to get like the approvals. But in terms of the second question, what was it? The second question?
The second question had to do with opening the pylorus.
Oh yeah, the
Using Botox.
yeah, so using Botox. So there, there has been some experience with Botox in gastroparesis in general. It has the studies have been sort of mixed, and the reality is, it's like I kind of like as I alluded to like in the earlier, is gastroparesis is a catch-all term, and it's sometimes it's due to the pylorus, like the opening of the stomach to the intestine. Sometimes it's due to that not opening up enough. But not all gastroparesis is due to that. It could be to the churning not happening, or the muscles or the stomach's not expanding to take in the food. There's a lot of ways to get gastroparesis. And so if you don't have that form of gastroparesis where the pylorus is not opening up, it probably won't be that helpful. But it's still, an experimental treatment that might have some benefit. There's also things like it's called G-POEM, where they actually cut the pylorus muscle to try to open things up. And that's kind of experimental too. It's not something like I would say definitely that's going to help you and fix all your problems. It has to be a select patient population where, at least from a physiology standpoint, it makes sense, but it's not guaranteed. But it could be an option.
I want to thank you so much. That's all the time we have for questions. We've run a couple minutes over here, but this was so informative and so wonderful. And hopefully, for those of you, by the way, that were not able to get in, we did have a little problem with Zoom, had a malfunction, but this has been recorded, so you can go to our YouTube channel and you'll be able to see the whole presentation. I just want to thank you again. I'm so appreciative. This was a wonderful presentation. And please check back with us with PCLA. We have a couple upcoming events in March. And on March 17th, excuse me, we have Dr. Eric Johnson will be talking about driving and Parkinson's, another very hot topic. And then on March 28th, as part of our Women's History Month, we have Let's Talk Women with Parkinson's. Join us for an interactive panel and discussion about women living with Parkinson's disease. And of course, we want to thank our sponsors, Abbott, AbbVie, Boston Scientific, and Medtronic. And of course, we want to thank you for joining us today. Please, if you enjoy having free presentations like this, donate today at PCLA.org. We are a 501(c) nonprofit, and all donations are tax deductible. So thank you so much for joining us today. Thank you, Dr. Elna Nashef. We enjoyed this most. It was a wonderful, wonderful presentation, and we will see you all soon at our next one. Thank you so much.
Thank you.